All right. Well, thank you. Again, welcome everyone, and hopefully most of you are making it into the webinar. But I think that we sent the materials out to you as well. So if you guys could just go to the next slide, to the agenda. We do have just a couple of sort of quick opening updates, if you will, on with Jody and Steve Posnack on the framework, and a couple of other quick items. But the meat of the discussion today is really going to be with our speakers. We're going to have some in-depth discussion of sort of trust approaches. So I think that will be really interesting, and hopefully we'll have some good exchange of ideas there. So I'd like to just ask, I'd like to turn it over to Jody to make some opening remarks.
Can you hear me?
Yes, we can hear you, Jody.
Great. So I'm still in the process of getting online, so I can't see what you all are looking at, but I'm going to be pretty brief anyway. So we should be on the slide after the agenda. I just wanted to thank everybody for participating. We really appreciate your and engagement in this forum. We were really pleased with the dialogue during the kickoff meeting, and we already started to get into some meaty discussions, and I'm really looking forward to the efforts of the forum going ahead. As just a couple of high-level points I wanted to remind folks of. As I mentioned during the kickoff call, this forum is focused on health information exchange at a national level. So we're talking about exchange also between different exchange organizations and across state boundaries. We're not seeking to talk about the internal operations of an organization at any particular level or addressing the governance of a single health information exchange organization. So we're looking a little bit more broadly when we're talking about governance and HIE in this forum. We do recognize and respect the variations in governance approaches that exist currently, and we will seek to identify where there are some commonalities or best practices without talking about one-size-fits-all solutions. We understand there's variability. Some of that really does make sense for particular types of health information exchange or different locations, but we are trying to look at where there is either commonality, best practices, or things that folks may want to strive toward. This morning, ONC released a governance framework for trusted electronic health information exchange. We were told in comments to our RFI when we were advised not to put forward proposed regulations at the time that we should put out a policy framework for private actors to align with, so folks know what are some of the most important things that they should be thinking about or what actions they should be taking or driving toward as folks are establishing governance for health information exchange. The governance framework reflects what matters most to ONC when it comes to HIE and governance and the principles in which ONC believes. So these aren't prescriptive practices or operating procedures. It's more at a principle level and things that we are hoping that will provide a common foundation for all different types of governance models can align to and different governance entities can align with. It's our hope that that folks will look to the governance framework principles as a way to align their work with national priorities and national principles, and we do expect to use these principles to shape the efforts and the discussions of this forum as well. So it is something that we hope will help channel the conversations that we're having toward those things that we see as national priorities as we're looking at national health information exchange and national health information exchange governance. To get into more detail on this, so I don't expect people have looked at this yet or read this, I'm going to introduce Steve Posnack, who is the director of our Federal Policy Division in ONC, to walk through briefly the governance framework, what's in it, and the significance of it. Steve, are you on the line?
Yep. Are we ready to rock and roll? So this is Steve Posnack from ONC. You can go to the next slide. And as Jody just mentioned, we are really pleased to have released today what we've called the Governance Framework for Trusted Electronic Health Information Exchange. Jody stole a little bit of my thunder in some of the background and context, but these are really meant to represent, as part of the governance framework, ONC's guiding principles for HIE governance. And what we really see, in addition to kind of flexing our convening muscles, which is what we're doing with you all today, also using these as a way to set direction and to explain our priorities to focus discussions on key issues. And so the governance framework is meant to provide a common conceptual foundation applicable to all types of governance models and to express the principles ONC believes are most important for HIE governance. Going forward, this is going to serve really as a pillar for how ONC approaches governance for electronic health information exchange. It reflects our current thinking today, including the recommendations of the HIE Policy Committee, the HIE Standards Committee, and draws from our prior expertise authoring the Nationwide Privacy and Security Framework, as well as all the work we've done over the past several years administering various initiatives to promote electronic health information exchange all the way from local to national levels. Over time, we absolutely expect to update and adapt the governance framework and its principles to include and reflect new innovations, stakeholder feedback, policy changes, technological maturity. You may see as you read through the framework, you may have a reaction like, this is impossible today. And that's why they are, I would remind folks, expressed at a principle level. We respect and expect that there will be things that are aspirational for folks, but we were, I think, heard loud and clear through the RFI comments that one of our roles was to set direction and to point towards the next milestones in the future. And that's what we're really hoping that this governance framework will help folks do and focus on going forward. So next slide, please. I have breaking news at the desk here that Matt from NEHIC will be sending you this document as well, although it is accessible on our website through a new Health IT Buzz blog that just got posted from Farzad. So continuing on, the governance framework's target audience really relates to, is intended to be and include any entity that sets HIE policy. So whether it be state governments, public-private partnerships, health information exchange organizations, private companies, many of which I think are part of this forum. And so you should find yourself being the kind of general intended audience. And in contrast, it's not really meant to speak directly to the, what I will call, for lack of a better word, the users of the electronic exchange services that would be governed by the types of entities that would be setting the HIE policy. So that's kind of one aspect and dimension and facet of the governance framework. We also believe that, as we've seen, there is some new kind of budding interest from different actors out there in the space for third-party assessors, whether it be certifying particular activities or accrediting particular organizations with respect to their electronic health information exchange practices, that they may also find the governance framework's guiding principles as an informative tool to develop methods to assess competency, credibility, and trustworthiness of the HIE governance entities that are there for setting policy. So next slide, please. Gave folks a little bit of a teaser into where we're going the last forum, and this is just a little bit more detail. I didn't think that it would be worth folks' time to kind of delve into each of the individual principles for all of these categories, since you wouldn't have had necessarily the context or benefit of having read through the full context of the document. So just again, as my kind of closing slide, we've grouped them into 4 categories of principles, organizational principles, which are meant to reflect the way in which ONC believes an entity that sets HIE policy should perform its duties. So really the kind of embodiment and practice of good governance by those that set the policy. Trust principles, which are critical from our perspective, and we frame these from the basis of what we believe should be patients should have as a belief and an expectation. Business principles to reflect the standards of behaviors that ONC believes an entity that sets HIE policies should strive to establish. So not telling people what they should do, how they should operate their business, but really how we believe appropriately performing their roles in the market should continue. And then technical principles, which don't get down into the level of using a specific HL7 standard or IHE profile, but more to express a kind of prioritization and direction for looking to those standards first that are nationally adopted, whether it be through regulation or through other means, and moving through kind of a continuum of those areas, as well as areas where we would encourage folks to participate in activities to make sure that standards adoption and development continue to accelerate, and there is work to participate in pilots and to further collaboration on areas where interoperability is going to be important. So that's really just a very quick thumbnail sketch, whirlwind tour of the governance framework. I would encourage folks to read it when you get it in your inbox, or have an opportunity to go on to the healthit.gov website and read Farzad's blog. And then I'm sure we'll have subsequent discussions with you all about how to best leverage this work as you go through your discussions over time, as Jody mentioned. And I will turn it over to, I think, Kate.
All right. Thank you, Steve. So if you guys want to go to the next slide, please. I'm just going to cover a couple of brief items, and then we'll get into the details. But given that the purpose of this forum is really about, shining a light on good governance practices, bringing HIE leaders together to develop a common understanding of governance components, and to identify high-impact issues and build on that. So a key next step in this process will, and some of it has already begun, but we're going to expand on this. And so we're going to be doing some data gathering, and we plan to use the framework of principles that Steve just described as kind of the structure for gathering data as we go forward. So, if you think about it, what we're trying to do is build a landscape of health information exchange governance practices through this effort. So again, using this framework of principles as a structure. So we're going to be following up with all of you, and some of you we have already, to ask for some information on your policies and practices in terms of how they address the items kind of in the framework of principles document. So that's sort of a key next step we wanted to make you aware of. And here, this link, for those of you who have made it into the webinar, the link on this page is where you can access the framework of principles. So it's www.healthit.gov/HIE governance. So that's where you can find those materials. Next slide, please. And real quick, as you guys recall, because many of you responded, we did send out a note last week basically announcing that in response to some of the comments in the first meeting and some of the suggestions subsequently, we'd like to create a steering committee as part of this National HIE Governance Forum. And the purpose of this steering committee will really be to provide direction and guidance to this effort and help us build consensus as we go along. So we're really, we want to make sure we've got a balanced group. We're thinking probably about 5 people, and it will require some time commitment in between our these regular HIE Governance Forum meetings. So, and we're really pleased that quite a few of you have already kind of stepped up and volunteered. And the nominations are open until Monday, so you can still kind of raise your hand if you're interested in doing this, playing this role. And so shortly after that, we'll be taking a look at everyone and thinking about, how to make sure we get a good balanced leadership group, and we'll be communicating that shortly thereafter. And even for those of you who obviously are interested in kind of a leadership role, if you don't get on the steering committee, I think we may certainly have other work groups, and so there will be lots of opportunities to participate in shaping the work of this group. So I'll just pause there for a moment to see, are there any questions based on what we've covered so far? And I'm pretty sure all of you, unless you've muted yourself, you're all able to talk, or if you'd like to raise your hand, I can call on you. So we'll just sort of scan here. I don't see anyone's hands up. So with that, I'd like to go to our presentations. And just to tee this up a little bit, we have asked a couple of people to talk today, to share sort of in particular how they are handling basically the sort of trust elements related to health information exchange governance. And what we mean by trust elements here are things like privacy and security, data uses, access to data, identity assurance, and sort of what are the most important things that need to be in place to build trust and enable trust and trusted information exchange. So that's what we've asked our speakers to cover today, and we're really excited to have Brian A. here on behalf of Direct Trust. I believe David Kibbe actually is on the phone, but he's not able to be online. And then we'll have Marianne Yeager to talk about HIE, and David Whitlinger on New York eHealth Collaborative. So with that, Brian, are you ready to go?
I am. Let's do it.
Wonderful, wonderful. Go ahead.
Well, thanks, Kate, and thanks everyone for coming online. If we go to the next slide, just kind of to give you some context for what we're going to talk about. If you don't know, Direct Trust is a nonprofit that was started a while back, and there are some background slides at the end of the presentation, and these slides are available on the HIE website, so you can always download these slides for reference material. And Direct Trust is also one of the organizations, along with the Interoperability Work Group, that is working under a cooperative agreement funding with the ONC on the Exemplar Health Information Exchange Governance Program. And so this really springs from last November, when we had ONC convened a Scalable Trust meeting in DC, and we'll talk a little bit about some of the outcomes of that meeting and how it got us to where we are today, but it was widely recognized that we really needed to scale trust in order to scale exchange. And so if we go to the next slide, there's special privacy and security concerns whenever you're transporting health information, which has legal protections, and it can be sensitive. And doing this on an insecure network like the internet, where no one knows that you're a dog, right? And so to effectively address these concerns, the Direct Project specifications use public key infrastructure, or PKI, to protect information exchange over the internet using X509 digital certificates and public-private keys. And we'll get into the meat of that a little bit more in some further slides. So the next slide, the key issues that we identified from Scalable Trust around identity and security, that first off, using direct over the internet, as I said, we have to make sure that it's secure. And so there's certificates that ensure the fidelity of the messages. And the sender and receiver have to depend on each other for identity validation and encryption of the messages and attachments. And so you have to have trust established between two service providers, or health information service providers, HISPs. And if you don't have trust, you can't exchange. So there's roles for what we're calling trusted agents, who supply identity validation and encryption. And these are critical. So, this really started back in the Direct Project. There was a Rules of the Road work group, and that eventually became Direct Trust. And the that was done in that work group. And really thinking about what constitutes sufficient trust and how can we avoid the costly, time-consuming contracts, the one-off connections, and the difficulty of trying to scale this at a national level. So if you go to the next slide, what we're trying to do is create a network that doesn't use bidirectional contracts, because that's unworkable. Having sort of the n-squared problem that I'll talk about in a little bit. The next slide talks a little bit about what scalable trust is. For many of you I know were at the Scalable Trust meeting last year, but some of you that weren't, and then also just for review, scalable trust is a strategy for enabling directed exchange between a large number of endpoints. So we think in terms of the internet itself and having billions of endpoints. We want to have at least thousands of endpoints and many, many thousands of endpoints and what I like to call the health internet. And in order for that to happen, it needs to be scalable. So that's sort of the background for what we're talking about here with scalable trust. And if it's scalable, then trust would happen quickly and uniformly. We could have a complete network that's formed voluntarily, and this will lower the complexity and cost. And the network effect would be a byproduct. So the next slide kind of gives you just a glimpse of what the network effect is, and I'm sure most of you have probably heard about this, where the value of a product or service increases as the number of users increase. And it also then decreases cost. The next slide, we'll talk about this n-squared problem, because this is sort of where we are today over on the left, the bidirectional contracts model. And if you have a health information service provider and you have 8 of them and they all want to connect with each other, it requires 28 separate agreements and contracts to connect, and also the technical ability for them to exchange certificates. And I'm going to talk a little bit in a minute about that, because there's something that's called a trust anchor, and then we can bundle those into trust anchor bundles and distribute those. And using the accreditation model you see on the right, not only can you require fewer contracts for everyone to connect, but you can also, if we go to the next slide, you'll see the centralized trust anchor bundle store that Direct Trust is developing, along with, in a cooperative agreement, aligned with the governance strategy of the ONC. And so, up on the right, you see HIE 1 through 5. That's obviously better than what you see down in the bottom, HISP, D, E, and F, where those are based on bidirectional contracts. And it's much better if you have a participation agreement and you can get all those HISPs together and exchanging. But what we think might even be better if we have a national accreditation program for HISPs and a centralized trust anchor bundle store for distribution of trust bundles. And so just to kind of step back as you're looking at this and thinking about the basics of how a trust is established. I mean, if you have 2 HISPs that want to communicate, first they have to determine that they want to send information to each other. And then they have to have a way to discover each other's public keys using the Direct Project's applicability statement. And this way, messages and attachments can be decrypted. And then they have to store each other's trust anchors so that they can assure the validity of those public keys to use. And most likely, those trust anchors are associated with the root certificates of those public keys. And there's also the ability then to, let's go to the next slide, because this kind of shows the Direct Trust framework that we have. And in the X509 architecture, a root certificate is the trust anchor and the whole chain of trust is derived from that. And so a trust anchor has to be in possession of the trusting party beforehand so that they can make any further certificate path validations possible. And So what that means is that in order to exchange these certificates, you have to have trust anchors. And so what we've kind of developed is the idea of having a trust community and a mechanism for distribution of trusted anchor bundles. And through an accreditation program with the Electronic Healthcare Network Accreditation Commission, or ENAC, which you're probably familiar with, and which now we do have in partnership with them a direct trust accreditation program. And so, you know, in the previous slide you saw what that means is that the more and more people that we have accredited through that program, and that we have their trust anchors in our Trusted Anchor Bundle store, and the distribution mechanism through, through the accreditation program allows us to really scale trust, I believe, using direct. And so with that, I do want to make sure that I leave enough time for the other presenters, and then also that we have some time for Q&A. There's a few more slides, and if you just want to whip through those, I'm not really going to discuss them in any detail. It's some background on Direct Trust. We're a nonprofit. We have already launched the accreditation program with ENAC, and we are even now distributing Trusted Anchor Bundles to accredited HISPs, certificate authorities and registration authorities for federation within the circle of trust in this trust community. And in the next slide, it says our mission, as a nonprofit, we have a board and a mission and a governing structure just for the business of Direct Trust. The next slide shows the members, the current members. Actually, I think there's, oh wait, we skipped around, didn't we? Sorry about that. So the next slide is the evolution of Direct Trust, and starting, as I said earlier, with the Rules of the Road work group, and then moving pretty quickly through to being awarded the ONC HIE Cooperative Agreement in March. And it's a one-year funding opportunity and a one-year opportunity for us to leverage the work of the community and really, I think, enable healthcare providers and to be able to achieve the health information exchange requirements of Stage 2 meaningful use in a scalable and simpler way. And then I think there's probably one more slide. Yeah, the assets of Direct Trust. And so, we have the accreditation program is launched. The Trusted Anchor Bundle Distribution Service is launched, although we're still working, obviously, to get this all up and going so that, we can have that network effect. I think it would be nice if we had, 57 states and territories and all those HIEs and all the service area HIEs and health information exchange organizations around the country that are using Direct as part of the accreditation program, and able to then distribute their anchor bundles through our distributed service. And with that, I'll pass it on to Mary Ann, and we'll take questions later on.
Thank you, Brian. That was really fantastic. This is Kate, and it's kind of amazing to think how far Direct has come since it was essentially just invented 2 or 3 years ago. So it's amazing to see how, again, all the progress. So if you guys could go to the next slide, I wanted to just ask Mary Ann Yeager to walk through again eHealth Exchange.
Okay, great. Thanks, Kate. Can you hear me okay?
Yep, you sound good.
Fabulous. Well, if you go to the next slide, we didn't want to go into too much background regarding the eHealth Exchange, but for those of you who may not be familiar, the eHealth Exchange, formerly called the Nationwide Health Information Network Exchange when it was run by ONC as a federal program initiative, it's basically a community of exchange partners who are bound by a shared trust framework and rules of the road. What that basically means is that each participant signs today a legal agreement that requires them to comply with a common set of standards and technical specifications and testing requirements and policies. And by signing that agreement and going through a testing process, it enables them to share data with any of the other participants in the network. And this is the nodes in the network, or the participants in the network, are very diverse. They're communities, integrated delivery networks, other types of networks, states, regional HIOs, federal agencies. So if you think about it, there's no middleman or intermediary in the middle. Healthy Way powers this network, and the only thing in the middle is really the legal agreement, which codifies the shared rules of the road. It basically points to the set of technical specifications and test cases and other things. And in addition, Healthy Way manages the digital certificates, which are issued to participants once they've demonstrated that they've met their policy and technical requirements. And we also manage the registry that's sort of like the phone book or directory of participants in the network, so that they know who supports the profiles that they want to support in production, and it also points them to the how they can connect to them. So I know we wanted to talk about the policy framework, and so a lot of times when we talk about it, we tend to talk about the legal agreement. But to be honest, I would say 90% of the discussions that revolved around developing this legal agreement were definitely discussing policy and principles, many of which are even in the HIE governance framework that ONC has just published. So if you think about this, this was actually developed starting back in 2007. The first iteration of the DRSA was developed in less than 90 days, and it was a test data agreement, and that really served to focus the group, this was actually developed as part of a federal program initiative that included representatives from the private sector, health information exchange organizations, IDNs. There were 4 states and 8 federal agencies who basically sat around the table, not attorneys. There was only one legal representative permitted for each of those organizations, but it was really business policy, privacy, security, technical people to really map out what was minimally needed for all of these very diverse groups to share data with each other. And so the first production agreement that was actually approved back in 2009, and the version that's currently in effect was actually amended in May 3rd, 2011. And incidentally today, so 2 years ago today, this actually went through very extensive review and vetting, including a multi-agency federal clearance process. And what that means is that to be cleared, it had to go through a very formal legal review and also across agency review across all the areas within HHS. And if you think about the scope of this, I mean, this is the CDC, Indian Health Services, SAMHSA, OCR, CMS, and all the other offices who had an opportunity to voice and weigh in, as well as very extensive review and input from the private sector, again, states and the broader community. As well as, in addition to HHS, there was also the clearance by Social Security Administration, Department of Veterans Affairs, and DOD. Today, there are 40 participants in production. There are 40 signatures to the very same agreement. And the only level of effort to get to that for the participants was basically to have their legal counsel review. So there have been no changes, again, since May 2011. So in the next slide, what we thought we'd do is just very briefly walk through what the policy underpinnings are, the assumptions of what is reflected in the DRSA. So sometimes when we think about the DRSA, we think about it, it's only a legal agreement, when actually the richness of the policies within it, we think are actually have been a very important catalyst to allow the eHealth Exchange network to grow. I mentioned that we have 40 participants in production. There are another 50 who have signed the DRSA and who are preparing to test and onboard, and another 40 behind them who are undergoing legal review right now of the DRSA and preparing to onboard. So we have a pipeline of about 90 organizations that are in various stages of either applying or preparing to apply, or those who've already signed it preparing to test. So what's in the DRSA? So we tried to group these by topics, and some of them fit a little better than others. But as I mentioned, there's this shared framework, these shared set of rules of the road, and a governance process that binds all participants to a common set of technical requirements based upon the use cases they support, testing requirements to verify compliance with the technical requirements, policies. There's a shared governance structure called the Coordinating Committee that oversees this work, and there are accountability measures. So the repercussions if somebody does not abide by the policies or if they're not in compliance with the technology. There's both a process for dispute resolution and issue remediation, which could include, if it's egregious, suspension or termination. But there's also a process for adding or changing requirements over time. And that was important because the participants in the network wanted to know what to expect, that if they were going to be required to comply with requirements, they wanted to make sure that they had a voice in the process as those requirements were changed over time, and that there would be some realistic assessment of impact and that kind of thing, which really gets to the model of governance. And it's a representative governance model, so it was very important for the participants, so since they're delegating authority to an oversight committee, that they wanted to make sure that they were governed, that those who were governed had representation on that committee. And so that would assure that the needs of the group were appropriately considered, that there were methods for obtaining input, not only just among the committee members, but the broader community. This is actually facilitated through task groups and outreach and industry collaboration. But there's also a very formal change management process where participants have to be given an opportunity for comment, and they have measures that if they don't agree with the changes or the direction, that there's recourse and a method for dealing with that in a fair and open way. The agreement among the participants is that they also were assuming that everybody else who signs the DRSA is actually in production, and that they have all the things that you need to be a good, trustworthy exchange partner, meaning that they have other policies and agreements in place that are needed to have effective exchange, as well as the technical infrastructure, and that they also had appropriate mechanisms in place with their technology vendors to make sure that they also complied and could help the participant fulfill their obligations. This is, the next item is, I think, probably a lesser known fact, is that the eHealth Exchange actually supports multiple exchange methods and profiles. So each participant declares which use cases or profiles they support in production. And the DRSA and the policies within it basically support multiple exchange methods, or what are called transaction patterns. And today this includes push only. It also includes query retrieve, as well as publish subscribe. So the push model has been in production since 2009. And pardon me, we're actually in the process of evaluating whether or not to add the direct transport protocols to the set of specifications supported in the eHealth Exchange. We know that the policies are certainly would support that. We just don't know what the practical implications would be, or if there's value in it or whatever. But just so the group knows that the way this was mapped out was to have a common framework that could work irrespective of the technology and irrespective of the use case that was supported, and irrespective of the way in which data were moved. If you go to the next slide. There was quite a bit of discussion, as you can imagine, around trust. So the privacy and security obligations of participants are very clearly spelled out. It largely defers to applicable law, and it also establishes HIPAA as a contractual standard of performance. Now, this is primarily for those who are not otherwise subject to the HIPAA rules. And there are also specific requirements spelled out by policy and then also implemented technically for identification and authentication. So each user has to be identified and their identity verified before being granted access. They also have to be authenticated. There is the idea of local autonomy, recognizing that different participants may grant access to their users based upon differing laws and business practices. There's just a recognition that that is going to vary, and that participants can't discriminate on who they share data with simply because another participant has different access policies for their internal users. They also, there were express requirements around enterprise security. In addition to just being required to comply with law, there were specific requirements around the items noted there in the third sub-bullet. There's also the notion that the connectivity can only be used for a limited set of purposes. Now, these could be revisited over time, but the use cases that were contemplated back when the DRSA was developed and that remain true today included treatment where the party submitting or requesting the data actually has a treatment relationship with the individual subject of the message. There are very, very limited payment and healthcare operational purposes, so those are narrowly constrained or much more conservative than HIPAA. It would permit the transmission of data for public health reporting purposes, as well as to demonstrate meaningful use, and to the extent that an individual had provided and authorized the release of information, that they could do so as well. In terms of future use of data, the assumption is that once data are received and integrated into the end user system, that it can be reused or disclosed in accordance with applicable law and local retention policies. Probably one of the most important things through all of these is that the governing law, there wasn't any one particular state or governing law established across the network. It was a recognition that we had to come up with a framework that established a neutral approach that could work across all 50 states and across governmental and private sector organizations. And since we actually do have a footprint in all 50 states and have quite a few governmental entities, both state and federal, participating, we've actually found that it worked really well to defer to applicable law and to only really focus on the things where there had to be uniformity above and beyond that. The next slide gets to some additional mechanisms around trust. There is a breach notification process. It's important to note here that this really just pertains to breaches that involve the transmission of the data among participants. I mentioned before that there is a need to flow down trust to participant users and to their technology partners. And I don't know if chain of trust is the right word or not, because it has some connotations itself, but the net here is that it addresses the need for trust to really extend to those who may be once or twice removed from a participant, and there needed to be a trust that there would be the same level of privacy and security whether a participant was exchanging directly on behalf of their users or if there are other intermediaries involved. To the extent that a request for information is based upon an authorization, the copy of that authorization also has to be sent along with the data. So finally, and this is probably one of the most important items, were on the next slide, the responsibilities of participants. And so I'm sure there'll be lots of questions later, but the idea is that if participants are going to query data for treatment purposes, that they also have a duty to respond to requests for treatment purposes. Now, they aren't required to necessarily disclose the data, but to basically be available for those requests. So they would respond either with a copy of the data as they're permitted to release it, or with a standardized response that data are not available. And in the early days, there were a handful of organizations who really were only willing to request records, but they would never ever release information to anyone else in the network, and that sort of made it a very one-sided approach. And so the idea was to have really equality in the participants so that somebody wouldn't come forward and only request information but never ever be available to respond to requests for data. The next one is probably the most important policy to map out, and that was establishing the responsibilities of the party submitting data. So it's the responsibility of the participant who submits information that they do so in compliance with the law that pertains to them. And they are also asserting that they are submitting that data for a purpose that's permitted by the DRSA, that they have the requisite authority to do so, and that by sending that data, they're doing so with appropriate legal authority, which means if they are required to obtain an individual's consent or authorization, if that's required by law, that they in fact have gotten that legal permission, and that they are sending it to the intended recipient. Now, all in all, if there are issues that come up, there are several avenues for resolving that, one of which is a non-binding dispute resolution process. The idea was to try to remediate and have a way for participants to resolve issues without necessarily resorting to legal action. And so we've never had to use that process, but it's there if needed. So with that, I'll pause and turn it back to Kate.
All right, thank you so much, Marianne. And I would like to just turn it over to David Whitlinger, and I hope all of you are thinking about questions, because I think we certainly will have time for some discussion. And I recall from our first meeting, this is not a shy group. So, Dave, you ready to go?
I am. Can you hear me okay?
Yeah, we can hear you fine. Thank you.
And you have control, right?
We do. So just just say next slide when you're ready. So
okay. Next slide, please. There we go. Keep going. All right. Just as a bit of context, in case you weren't aware, New York formed 12 different RIOs originally, health information exchanges, back in the 2007 and 8 time frame. Really got rolling in 2009. Each of those health information exchanges with its own board, governance, region, providers, payers, and fairly robust regions. So if you think of the New York State, 20 million people, roughly 20 million people, each of those health information exchanges roughly equivalent to about 1.2 million people on its own. So not small in each of their own sizes. Next slide, please. So what was set out back in that time frame, each of those health information exchanges was actually under contract with New York State Department of Health under a grant program called HIE. And that grant program, in addition to requiring deliverables and paying for those deliverables in normal grant-like fashion, also had some language in there with regards to, and the RIO shall be beholden to and will follow statewide policy. And statewide policy being the data use and privacy and security policies that were established by a policy committee that was facilitated by NICE, but ultimately those policies sanctioned by the Department of Health. So at the time that all of this was assembled using the grants back in 2009, there were a number, those grants, those contracts held the governance, if you will, or the adherence to policy together using that contract. And the policies, when the whole thing began, it was a blank page, and the policies over time grew to be fairly robust. So that the policies dictate how to manage consent, how to manage data usage, the depth of the security protocols on the network. They're pretty strong and robust. We're actually now in the process of reorganizing them and creating a document that is straight policy and a document that is implementation, so that it's a little bit cleaner. But all told, both of those documents are well over 100 pages of pretty specific stuff on just data use, privacy, and security, and so forth. There were also a set of technical policies that were developed during that time in order to foster interoperability, but as some of you may know, at that time the market didn't have meaningful use dollars flowing. The different market dynamics were such that interoperability was a challenge, even with New York trying to use some influence as a single state, and that ultimately those technology standards were not heavily adopted. We struck that up again with the interoperability work group when meaningful use came around, and believe we're much more successful in partnering with CCHIT and with Healthy Way in order to accomplish some greater interoperability, but we won't spend time on that today. So here we are, fast forward. The grant dollars are running out. That's per the course of that. The startup, if you will, is nearly over. And so now we're putting in place the next iteration of adherence to network and the constructs around that in order to move from the grant contract mechanisms to a new governance model. So what you see on this slide is where we stand today. We have the Department of Health that oversees the functions of the HIE, the State Health Information Network, through contracts and funding. They sit on the boards. They're part of the governance model. We have NICE, which is a 501c3. It has its own board of directors that is a very fairly balanced table from around the state and across the different segments of the industry. And then each of the RIOs, each of the 11 RIOs, have a board of up to roughly 20 people, and again, within that community, very balanced table, so payers, providers, and so forth. Some of the RIOs have their own policy committee, and that policy committee may determine how to implement individual policies if there's latitude allowed for those policies. But for the most part, over time, we've been reducing that latitude so that there's greater and greater consistency. Next slide, please. Moving forward, the department felt very strongly about putting forward, let's make sure that these principles are always kept in mind as we advance the governance process of the network, the HIE, and that is to continue to maintain it as a public-private partnership. That we see this as a great use of the different tools from both sides, either side of the fence. On one side, of course, there's regulatory and legislative authority, as well as at times the department as a payer. And then on the other side, we have the ability to nimbly deliver technology services and work very intimately in collaboration with the healthcare community very, very heavily. So there's a great partnership there that works well. And I have to say, one of the more interesting things that I think comes from this, the phrase healthcare is local is a very, very strong mantra for good reason. And as you can see, trust only goes so far, and I think that actually it does have geographic bounds that we've discovered in New York, and I can talk more about that after I rip through the slides here. And that goes from both the personal level with individual healthcare as well as with the provider community. Then we have this statewide framework that we're going to continue to use this to the public good, that because we've created this great investment, we have the ability to continue to leverage it as a public good, as a public utility, as a public infrastructure. So it doesn't solely take on a market-driven approach for market purposes that may or may not always serve the public good and may not always serve all aspects of healthcare. So that is a fairly strong element of what we want to continue to move forward with. Public health will never be forgotten. That could be something that happens if this was a private-run network, and that we want to continue with the partnership of financing it both publicly and privately. With those HIE grants, they always had a match component to them, so the amount of private money that was also invested in developing the network was not insignificant. The state is now also looking at different regulatory levers because of us moving the network forward. We are, interestingly enough, from an adoption standpoint, at a very interesting point. We're in some communities past the tipping point, if you will, where there are enough users and there's enough consent to usage of the data that is in the network that the usage of the network is dramatically increasing on a day-to-day basis, and the percentage of adoption is increasing in those communities rapidly. In other communities, we're not quite to that tipping point yet, and it's got a bit of a chicken and egg to it. If you don't have enough data in the network, people don't find it valuable, and so they don't use it, and so then people don't use it, and so they don't join it, and so you end up into a little bit of a stasis. And so we are in some communities we're not seeing as great a growth as we'd like. So the state is looking at different levers to apply because the value is now quite apparent in those mature geographies. So we'll be looking at different levers. You may be aware that Massachusetts passed a law that essentially says you can't be licensed to practice medicine in the state after 2015 if you don't have an electronic health record. Those are the kinds of things that might be employed here. Next slide, please. Here's roles and responsibilities, and this slide goes hand in glove with the next slide after this one. Essentially, the principal roles here are that the Department of Health continues to have overall authority on the HIE and use the regulation and funding to as different levers in applying that authority. They serve as a partner, and a very strong partner with us on through the governance processes. And they approve the statewide policies that they're adherence to law, and they ultimately at times will get elevated into a regulation or state statute. They certify the qualified entities. So this is the element of moving from a collection of RIOs to what we're calling qualified entities, or QEs. And so now we have an ability to test whether those qualified entities are adhering to the policies and providing the requisite services to their geography, and that's what this certification is about, is to, on a regular basis, test to see whether those entities that have been given that authority in that region and that service portfolio, that whether or not they are adhering to all the policies necessary to maintain trust and all the services necessary to have a quality network. And then last, support the public health purposes. NICE, the central nonprofit here, has two roles. One is the facilitator of that policy development, so continue to convene the stakeholders, develop the policies, both technical and non-technical policies, and propagate those throughout the network and become be the facilitator of that. And then also provide those technical services. I won't get into it today, but some of those RIOs, it doesn't make a lot of sense to have 11 different technical infrastructures to operate the network, although it makes a lot of sense to have 11 different organizational bodies because of the trust that endears. But we can provide technical services at a much, much, much lower price by bulking up on volume and commoditizing. So that's what we've done. So at least at this point, 6 of those 11 RIOs are using NICE as a technical service provider and enjoying a lower cost because of it. Then the far right, you can think of this as RIO or HIE, but as I said, we're shifting to a phrase of qualified entity, meaning that they've gone through a certification process, that they are a trusted deliverer of service on the network. And I think that's what's germane to this conversation today. Oh, that slide 26 reference is in the wrong spot. You'll see in another slide what we're describing as dial tone services. So we very much believe that everybody in the state of New York should be entitled to at least a basic set of services that is consistent across the entire state. And so that's what we're referring to as quote-unquote dial tone, that's the basic service. And if some of the qualified entities or RIOs wish to offer additional services and greater services, that's fine and good, but at least there's a minimum set of services across the entire state for all patients, providers, and payers and participants in the healthcare system. Second is that they are required to follow the statewide policy and oversee and enforce the statewide policy. We're thinking that there's a need for us to also, knowing where we are in the adoption, continue to march forward on the adoption targets and do that by setting goals on a regular basis with the qualified entities and seeking them to continue to market and sell the services to get to that level. I won't go through the rest of these. They're fairly consistent with supporting the public good. Next slide, please. These are the proposed dial tone services. It's going to go through another month or so of stakeholder review, but this is pretty close to being what will become the set of basic dial tone services. The way we've described this process is that the dial tone services will also undergo a revision every 2 years. So every 2 years we raise the bar, if you will, and include more in the basic package of what the network will provide, but we also keep it stable for a 2-year period, such that the qualified entities aren't trying to hit a moving target that's changing every month. So this set of basic services is where we're starting, and as I said, it's not finalized yet. It needs to go through another round of stakeholder review and discussion, but it's probably pretty close to being final. And as you can see, the first 3, patient record lookup, direct, and notifications, are very, very strong features of what a network can do. Consent management and identity management are pretty necessary from a standpoint of policy adherence and policy delivery. Incorporation of the public health, the ability for public health to be able to participate in the network is on the list. And lab results delivery is something that is there to describe how some of our more rural regions work because of the stronger usage of hospital or regional-based labs as opposed to national labs. Next slide, please. Here's the drawing of how the contracts hang together. So from the Department of Health, there's a memorandum, there we go, of understanding between Department of Health and NICE to facilitate the network and to operate on behalf of the department. And then there's a committee structure in order to create the policies and the work products that some of which you see described here that talk about how to govern the network and use the network. Then between NICE and each of the qualified entities, there's agreement that holds together they will be delivering the services, the dial tone services necessary, that they'll be doing enforcement to the policies, that there are penalties for not enforcing the policies and for bad actors on the network and so forth. And then there's participation agreements between those qualified entities and all of the individual healthcare providers or users, participants of the healthcare system. Wrapping around that is every 2 years a certification process where a third party will do an audit on that qualified entity to determine that they are adhering to policy and they're providing all the necessary services and so forth. Every off year, so every 12 months, there'll be a light audit done for the more impactful things that have to do with data use, privacy, and security, and so forth. So every 2 years, a full recertification, once a year, an audit just to determine whether that there's any gross errors with regards to adherence to policy. And then the bottom box down there shows the work group structure of continuing to develop the policy guidance. Next slide. Okay, so that's the full presentation. As I said, I think that's something that because of the trust factor here, let me offer one set of comments here. What I think New York being a large state, 20 million people, and the way it went down the path of investing in these different regions, we see without a doubt that there's a lot of strength in those regions with regards to trust. So each of those communities, they put together the leadership from around the community, about 1.2 million people. They got together their local public health department, their local large healthcare providers, IPAs, hospitals, insurance plans, and so forth, and formed a RIO. And when they started, they did not trust each other. You know, it was as all we frequently hear in health information exchange that those initial meetings are a bit rough, and they got to the point of trusting each other and then ultimately building a health information exchange together and sharing data and so forth. You see that same level of distrust when you start to talk about it at a state level. It's the same paradigm of what occurred in order to put that community together, but now at a different level when you talk about, okay, well, let's take these collection of 11 regional networks and put them together into a statewide network. And we're, this process that you just saw described here seems to be resolving a lot of the issues with regards to the distrust, because it's putting together a fabric of being able to share data and have a network that behaves and follows policy and polices itself. But at the same time, you do hear questions with regards to, well, should we allow for providers to have access to data that broadly, just because of what's the frequency of use, and not that people are inherently going to misuse it, but there's just opportunity. So how frequently does a doctor up in Buffalo need to access records on a patient who truly resides in Manhattan? And is there enough of a value there for us to open those doors and continue to share data at that broad level? And so that conversation of how far from your principal patient referral zone, your principal geography, will be ongoing, I believe. You know, we're starting with we do think that the data should be statewide and here too from a policy perspective. But we'll see. I think the jury is still out on whether or not that is the right sphere and breadth to share data. So with that, I'll shut up and let the discussion begin.
All right, thank you, Dave, and thank you all for those presentations. We do have about 15 minutes for questions and discussion, and you have a couple options. You all can unmute. You're able to talk, so if you want to just raise your hand if you'd like to make a comment or whatever, and we can have some sequencing there. We do have, maybe before we get into the questions, I wanted to sort of ask the three of you, in listening to each other, about the various different approaches. I mean, what are your thoughts initially about, what are the commonalities across the three of you, if you could each comment on that to get us started? So I'll jump in at once.
Well, I'll go first since I presented first, and then maybe we can just follow that same order. But I think we've got a particular interesting set of problems, and I've been mainly focused in the direct community around directed exchange and really getting the direct project, widely adopted and widely used. It's a useful tool, but it's only one of the tools available for health information exchange, and certainly the ability to connect into the broader exchange network is important. I think that some of the basic foundational work that NICE is doing and that Direct Trust are doing through this cooperative agreement is really going to help lay a foundation for that broader connectivity. And then, obviously, healthy way, everything seems to be moving nicely aligned and in concert. Healthy Way is now a public-private nonprofit, and I think the ONC took a hard look at the response to the request for information last year on governance and really listened to the community. And so, as others were talking, I was glancing through the framework, and I encourage everyone to take a look at that. We've got a lot of work to do, but I think by the end of this year, we're going to see some intersection between all these efforts.
Well, this is Mary, and I agree with what Brian's saying. I think there will probably be a convergence on the different national level models, but I'll say in terms of the very strong governance approach that NICE has implemented and the HIE has, that's what the eHealth Exchange assumes is in place. And there's a reliance that the participants in the eHealth Exchange have, production-ready, production-level governance and trust mechanisms in place. So I would say that's, I wouldn't say a dependency, but a very strong complement. I think the discussion is changing in terms of national level networks, and that we'll see convergence and alignment. I think they go hand in glove.
A couple of things that I'll mention as far as commonality. I think there is, value, a lot of value in what we are describing in different ways in different parts of the ecosystem and marketplace of these certification bodies for different pieces, because it does give assurance that a really set of complex policies or technologies or really complex pieces of the ecosystem that's hard for the end users to get their heads around, because it's not what they principally do. They do healthcare. That a bunch of that stuff is being adhered to the level that they can trust whatever it is that it's sticking to. So whether it's the certificate management and that kind of thing from the direct trust piece, or whether it's a standards body and you can trust that the technical standards were adhered to for interoperability, or whether it's a set of policy adherence in the certification body that attests that this policy adherence is being adhered to, such that the participants can trust that the network is secure and safe. Those bodies, I think, are going to be paramount and essential, and I would question whether or not they need to be varied, and whether every state needs its own, or whether or not there's an ability for that to be done more broadly and nationally. I think there is an interesting element of where we get to in regards to that, because as we're experiencing in the maturity of the New York marketplace, it's a given that direct is a necessity. As a point-to-point transactional exchange of records, one provider handing off a patient to another, here's the records, or however all those different kinds of patient relationships and provider relationships are managed today. I think there is some fear with regards to how wide you continue to expand the patient record lookup capability, because of what that can provide is a lot of rich data, but can provide it to a lot of people who may or may not need to have it and may or may not use it always in the best intent and purpose. And as you widen that circle, you increase risk. So that one, I think, is there's no question there's a lot of value for patient record lookup as a capability. I think that one's got all the trepidation around it with regards to how wide do you make that circle and what do you do with it.
Great. So we have one question that was typed in, and then David McCallie, I'll call on. I see you have your hand up. I'll call on you next. So this question is, has anyone evaluated how the ID and authentication process required by eHealth Exchange would work with Direct Trust from an implementation standpoint? So maybe Marianne and Brian, do you want to comment?
Well, this is Marianne. We haven't investigated it yet, but I think I mentioned before that we've actually are digging deeper into the compatibility of those approaches, because there's been some level of interest in adding the direct transport protocols to the eHealth Exchange set of specs, so that's something we'll be looking into. I don't know just yet. I can't imagine they'd be that far off.
And I think Marianne's exactly right that eventually we will see that occur, and there'll be the ability to step up and step down from direct to eHealth Exchange. I don't think we're anywhere close to that today, but it would certainly be something that I would want to see in the future.
Thank you. And David McCallie? Oh, sorry. Go ahead. Did you want to say something?
Just one. Just because we're in the practical implementation of, on one side we've got two-factor authentication and the need to strictly authenticate users of the network, predominantly for patient record lookup, and we're marrying that with the credentials then that have to get issued for each of those individuals, such that they then have a direct address that gets credentialed and gets used across the network. So we're in the process right now of marrying those systems together, marrying the workflow of establishing a user on our network and credentialing them, both from a two-factor authentication all the way up to a digital certificate set of mechanisms. So we're in the middle of it. So hopefully we'll have some best practices at some point.
Great. So David McCallie, did you want to ask a question or make a comment?
Yeah, it's a question. It may not be a terribly well-formed question because I'm still thinking about it, but to Brian and Marianne most directly, but I suspect Dave, you may want to comment as well. It's interesting that you all have PKI-based 509 certificate-based security at the root of, literally, pun intended, at the root of the models. The direct trust model uses an actual sort of certification process, a non-trivial, non-free certification process, which makes sense because that follows the model that works in other non-healthcare uses of PKI infrastructures. The eHealth Exchange seems to not go through that process, and I'm wondering, maybe Marianne, do you think the certification of the participants in the eHealth Exchange would become a necessity at some point, or are you handling your certificates in some way that doesn't require that? Or maybe the question to you, Brian, is that overkill to require certification when some of these other entities are not actually pursuing that policy? How does convergence occur in that space?
Well, I'll start just by pointing out that what Direct Trust is doing accreditation, not certification. So that's a fine point, but I think it's an important one because we are, in partnership with ENAC doing, and you're right, it is non-trivial, and it is a process that has to take place. Yet it provides, entrance into a trust community that then enables exchange more readily to take place. So I think it's incredibly valuable. But there is, when I first saw what the interoperability work group was doing with CCHA on certification, I was pretty excited by that work. And I think that certification, which is certification, and the accreditation for organizations and entities on the direct trust side really do go hand in hand. I guess, when you pull back and look at it from a policy perspective, and that's the question tossed to Mary Ann, is how that is eventually going to line up with eHealth Exchange. And it's a good question, and I don't really know the answer.
This is Mary Ann. I'm not sure I know the answer either. I mean, there was probably some more technical nuances of that. It would probably benefit an offline discussion with our CTO, or I can happily to invite him to the table to talk about it. But I think the distinction Brian makes is accurate. Healthy Way is working in collaboration with the New York eHealth Collaborative and the EHR HIE Interoperability Work Group. We have jointly are developing an HIE product certification program that will not only meet the needs of the eHealth Exchange in our community, but also the needs of the states, New York being one of the 19, is it, Dave, that have joined the collaborative, and to make sure that providers can connect to their community and that they can also, whether that's using sort of the SOAP-based approach and PDQ stuff or the direct. And so we felt that by aligning on product certification that we would help coalesce the market around more interoperability. And from an eHealth Exchange perspective, if somebody has signed the DRSA, they've demonstrated that they've implemented the flow-down provisions for trust, and they are using a technology that has met and passed this very robust testing and certification program, those are the basis in which we issue the digital certificates, which today for the eHealth Exchange are, system-level certs. We've not yet gotten deeper into how that plays down further in the trust chain, so to speak.
Yeah, and so David, I just clarify that I was referring to the accreditation for the proper handling of those certificates, and I apologize for using the word certification in a confusing way, but I think I just interrupted someone.
Well, no, I was just actually going to say that, one of the things that I think is important work that we're doing is the trust bundle distribution mechanism. And I think that this is complementary to the capability that's already exists in the direct certificate discovery using ENS and LDAP. And so, just in terms of, solving the N-squared problem for direct and being able to have scalable trust, I think that having accreditation as part and parcel with the trust anchor bundle distribution mechanism is really going to help a lot. Obviously, I think you're right, there's the eventual goal of being able to have that also incorporated into eHealth Exchange at some level.
Yeah, it's an interesting distinction as I think about your responses and think about the question itself. Is the one approach of signing the DRSA is kind of the gating event that qualifies you to be able to participate in the network. The other one is an accreditation process that qualifies you to be able to access the trust bundles, which is what lets you participate in the network. And so the question is, what's the equivalence between signing the DRSA and accreditation when you go to scale and when we flesh all this out? So I don't expect an answer, but that seems like a really interesting point where this convergence will need to occur.
So we're just about out of time, and one observation. I mean, this is Kate, and it seems like a lot of states are putting in place kind of an HIE certification type process. So it might be interesting as part of this process to see, looking at across some of those if they are actually common, and if there's something to learn from that. But so before we wrap, I mean, if each of you, each of the three of you, maybe comment on what you consider to be the biggest challenges associated with sort of the trust aspects of what you've got in place. What are some of the sort of most challenging issues or pain points that you're dealing with? Maybe Brian, do you want to start?
Sure. And I mean, just pulling back, thinking about at a higher level and governance of health information exchange in general, and looking at the framework that the ONC has in place now and how we're going to move forward. Obviously, the business practices and the sustainability of exchange and the business models that organizations are using and states are using. It's kind of exciting because it's almost like a Silicon Valley startup mentality, but at the same time, people are sometimes, I think, being too cautious, and we need to, if we want to succeed, we cannot fear failure, and we'll learn just as much from the things that don't work until we get to the things that actually do. And so I think, overcoming some of that fear of failure and finding business models that help us get to the next level are going to be key.
Well, this is Marianne. From my perspective, I don't know that it's a pain point, but I would say it's a focus area because we think we've worked through the kinks from the DRSA perspective, that the policies are well established, they're working, there aren't really even a lot of questions about them. I think where our focus area would be, I wouldn't call it a pain point, is trying to provide additional guidance on how to implement those flow down expectations for trust. And it sounds like the direct trust folks are looking at an accreditation model. That's something that the folks in New York have also looked at. And I don't know, is accreditation where this is going eventually? I don't know. I would say that we know we need to do more in terms of providing guidance to make sure that the organizations who are connecting through the eHealth Exchange have actually implemented and are trustworthy. And I think that's the bigger focus area. And then another big focus area, again, is really focusing on the product certification efforts with our partners here in New York.
Yeah, I guess just to build on my other colleagues here, I think there's a whole aspect of the technology stuff that how to move around certificates and how to do interoperability and so forth, that I would hope that we could actually move a little bit more, with a little bit more engineering deliberation and a little bit more speed, because a lot of that stuff can be done in a much more rapid, definitive way with this sounds wrong. It's not less collaboration, but it's there can be less opinion with regards to some of those solutions when they're put in the right context. But there's a whole bailiwick of technology stuff that could be moving at a faster pace and would take care of that aspect of what it is that we're trying to engender with regards to the usage of the internet for trust. I think on the other side is then how do we manage the usage of, and that I think is where we would do to spend a lot of time, is how wide and how substantial should those trust circles be.
Kate, this is Claudia. Can I just make a quick comment?
Sure, please.
I think one of the things that will be really important to tease out as we proceed in this conversation is where ONC can be helpful in accelerating the process that David just described. So if you remember, the framing is that, while we're not moving forward with a voluntary separate accreditation process because there's all this great stuff underway, to the extent that there is national priorities that are laid out and consensus in the community, it doesn't mean that ONC couldn't play a role in helping drive those forward in some way. So I think just as we go forward with these discussions, identifying, where is the impetus already there and things are moving forward and everyone's participating, and it's good to be transparent about that, versus what are those discrete either problems that need to be resolved or ways in which ONC or other federal government agencies could help accelerate progress.
And actually, Claudia, I mean, this is Kate. I think that would be a really good agenda item for, one of our next, meetings of this forum, to have that specific, get input on that specific question. I think that would be a really good idea. So with that, I think, we're out of time, and so thank you, in particular, Brian, Marianne, David, for leading the conversation today. I think that was really informative. The next meeting of this forum is going to be on May 29th, but we'll definitely be in touch long before then to continue the data gathering effort and to announce and engage with the steering committee. And then I also just wanted to make you all aware that on May 10th, there's going to be a webinar that NEHIC is going to host for ONC to provide an update on all of the various activities that they have underway related to health information exchange governance. So that might be of interest to all of you. So again, thanks everyone for participating. Oh, was somebody